Hello everybody. Over the next few minutes we will discuss what is the best imaging for men with hormone-sensitive prostate cancer. Should we stick to conventional imaging or should we be moving to next-generation imaging? As many of you know, this is a really hot topic. This is my disclosures. So I'm going to take the viewpoint that in fact bone scans and CT scans remain at the center of patient care despite known limitations, which I will acknowledge. I'll try to frame, therefore, the use of next generation imaging, be it multiparametric whole body MRI or PET CT scans, as problem solvers after bone scans and CT scans, because the use of next generation imaging can cloud patient management. I'll try to point out to you the very powerful nature of the prognostic roles of bone scans and CT scans and the very predictive nature of bone scans and CT scans to say you should use a particular therapy. But I will acknowledge that we also need to think about moving towards PET CT scans and whole body MRI scans, but with a higher level of evidence, particularly if you want to replace bone scans and CT scans in their current established roles. So we are talking about hormone-sensitive prostate cancer that is metastatic. So in this particular graphic, it's the area in pink where metastatic disease can be synchronous or metachronous, and it can be of high volume or it can be of low volume. You'll notice that high volume, low volume are determined by bone scans and CT scans, and remember that next generation imaging detects disease earlier than is detectable by bone scans and CT scans. Now, if you did conventional imaging, what distribution of disease would you find in metastatic hormone-sensitive prostate cancer? Clearly, bone metastases, more than 90%. Lymph nodal disease, thorax and liver, these are the predominant sites for metastatic disease in the hormone-sensitive state, and of course it can be single organ or multi-organ involvement. So if you look here at the distribution of disease, you can see how patients who have lymph nodal disease will have the better survival than patients with bone disease, and of course people with visceral metastases have the worst prognosis. And if you have a single site or a double site of disease, then if you have more than one site of disease, then you're more likely to have a poorer prognosis. Now, it's possible to classify patients into good prognosis and poor prognosis groups on the basis of risk. Low risk or high risk, high volume or low volume. And there are a number of definitions available out there. The most common ones tend to be the modified charted criteria, or in Europe, often the Stampede criteria. Now, if you looked at the effect of abiraterone, a common treatment used for metastatic hormone-sensitive prostate cancer, if you look on the top row, you'll see that's the overall survival by low risk and high risk disease. And you can see that both groups in fact benefit from the use of abiraterone. Now, of course, patients with lower volumes of disease are going to do better, but they still benefit. People with high volumes of disease also benefit, but of course to a lesser extent, as you might imagine. Now, it is important in hormone-sensitive prostate cancer to consider that there are different patient groups, not only high and low volume, but also by when the metastatic disease presents. So if you have metastatic disease at the outset, your prognosis is worse. If you develop metastatic disease sometime afterwards, metachronous metastatic disease, then your prognosis tends to be better. And in both of these groups, low volume and high volume are differentiating factors. Let me just show you that in this survival curve. So you can see how men with synchronous high volume disease have the worst survival. You can see on average about 3 years. If you have low volume disease that develops sometime after, in fact you have a much longer survival from the point of detection of the metastatic disease. So they present later and then they live longer still. And you can see that the difference between the two is about 5 years. Which means that these patient groups have different prognoses, and therefore the treatments that we offer would also be different. So if you had low volume metachronous disease with a good overall prognosis, you'd want to de-escalate their therapies, whereas if you presented with locally advanced disease and high risk, a large volume disease, then you'd want to escalate their therapies. Now, within the therapies that are available, some of these therapies have a predictive value on the basis of the bone scans and CT scans, and I just wanted to go through some of the ones that do in fact have a predictive value. So let's take somebody who presents sometime after the disease and it's of low volume, so oligometastatic metachronous disease. Do these patients benefit from metastasis-directed therapy, which is a de-escalated therapy? And of course they do. So there is a predictive role for bone scans and CT scans in metachronous hormone-sensitive prostate cancer of low volume disease. And here's a man with low volume disease sometime after his primary diagnosis, and you can see on the conventional imaging he has a single deposit. Is this conventional imaging suitable for planning of cyberknife radiotherapy? The answer to that is yes. So here is the Oriole study. In the Oriole study, they took 54 men with oligometastatic disease, less than 5 metastases, based on conventional imaging in either the bones or the nodes, so the good prognosis patients. And you can see that some patients had stereotactic radiotherapy, bottom left, 36 of these patients, and 18 went on to observations. And they were treated on the metastases that were depicted on the bone scan and CT scans alone, nothing else. And you can see on the right-hand side that the survival was better for those people who received cyberknife radiotherapy compared to those who were on observations. And of course this doesn't come as a surprise, but you'll notice that a number of patients in fact do develop progression. Why is that in the longer term? Why is that? Well, clearly it's because metastases that were not seen were not treated. So if you look very carefully at those 36 patients who received cyberknife radiotherapy, you can see about half of them had metastatic disease that was untreated. It was seen on the PSMA PET CT scans that were done at the same time, but they were not treated, and that accounts for this steady decline in progression later on during their course of treatment. But what we can say is that bone scans and CT scans did predict for a better outcome, and there's no doubt in a randomized study where this has been shown. I wanted to show you another example of the predictive role of bone scans and CT scans, this time looking at when the primary E is still in situ and you have low volume synchronous disease. So you present with a locally advanced prostate carcinoma and you want to find out whether you should or should not treat the pelvis given that there is metastatic disease. So what is the predictive value of bone scans and CT scans in synchronous low volume metastatic disease? And it turns out it's very good. So you can see on the top right hand side is the overall survival when you have less than 3 bone deposits. If you have less than 3 bone deposits on bone scans and CT scans, it's worth giving pelvic radiotherapy. If you have higher volumes of disease, it's not worth giving radiotherapy from a curative perspective because the overall survival does not improve. And it is for this reason that the ESMO guidelines in 2000 said that patients with high-risk locally advanced disease should be staged with bone scans and CT scans. And that if you have localized disease on these conventional imaging, you should not be denied radical radiotherapy just because some next-generation imaging showed you more deposits than you were expecting. Now, let's talk about the predictive role of bone scans and CT scans in terms of docetaxel chemotherapy. Here there has been quite a lot of controversy. So let's talk about the predictive role of bone scans and CT scans for the use of docetaxel chemotherapy. This is some data that's recently been released at ASCO in 2022. This looked at men in 3 large randomized studies, and everybody was classified as being high volume or low volume, metachronous or synchronous, and then we knew what the overall survival of these patients are. Now, if you look at the top graph, and I'll just magnify that up for you, you can see that men with metachronous, low volume disease, so low volume disease that presents sometime after the initial tumor is treated, do not seem to benefit from the use of docetaxel, and that's shown here in the green, or this bar over here. Whereas all other men, you can see here, do benefit from the use of docetaxel chemotherapy. Now, who were the men with higher volumes of disease who benefit the most? And that's shown on the bottom left. So let's magnify that up. And you can see that the people who benefit the most from the use of docetaxel are men who have synchronous disease of high volume with locally advanced prostate cancer. So if you have a locally advanced prostate cancer and lots of bone deposits, you are most likely to benefit from the use of docetaxel. Somebody like this, for example, locally advanced prostate cancer, nodal disease in the pelvis, nodal disease in the chest, and lots of bone deposits. These patients definitely benefit from first-line docetaxel. You can see how powerful these technologies are at saying, use this therapy, predictive value. So what we're saying is, no benefit for docetaxel in the lower volume metachronous state, high benefit for docetaxel use with locally advanced prostate cancer with high volume metastatic disease. Now, are there other patients who would benefit from the use of next generation imaging technologies after you've done the bone scans and CT scans? It turns out there are. So let's take these low volume metachronous patients who would not normally benefit. There are some patients in there that would in fact benefit, and these patients should be looked at by next generation imaging. Here is such a patient. You can see this man presents 6 years after his primary tumor is treated with what looks like low volume, low risk metachronous disease, and you can see the bone scans. There's a few spots up there, but it looks like low volume, but he's got red flags. The red flags are pain and anemia. So if you see red flags in this situation, you should always consider doing next generation imaging, and we did whole body MRI scans. And you can see he's got large volume disease. He's got a spinal cord compression. So he went from potentially being treated with ADT alone or a next generation androgen signaling inhibitor therapy to, in fact, in the end, getting docetaxel because he has higher volumes of disease, and of course radiotherapy in this particular instance to the dorsal spine. So these red flags are important. So if you have a red flag, such as your clinical impression, the presence of pain, anemia, an LDH level, an alkaline phosphatase level, or a PSA that doesn't seem quite right, either metachronous or synchronous, you should be thinking about using next generation imaging, because these are the very patients you will be able to help. Now, there are some patients with synchronous low volume disease. So at the time, they have low volume disease. Some of these patients will in fact benefit from the use of next generation imaging technologies. And in fact, the ASCO guidelines also says that. But it says that you should use it after bone scans and CT scans. So when conventional imaging is suspicious or equivocal, next generation may be offered for clarification of equivocal findings if finding more disease would alter patient management. Let me show you an example. So here's a man with high-risk locally advanced prostate cancer, Gleason 9, T3A disease. You can see here a bone scan and a CT scan, and you can see two abnormalities on the bone scan. Both of these sites are negative on the CT scan. So these are equivocal abnormalities. Are these deposits? Is this in fact oligometastatic disease? Should he have prostate radiotherapy? Yes, we've already said that. So he should have prostate radiotherapy. He should ignore any other findings, but he qualifies for that. So it's a predictive role of bone scans and CT scans. But you are allowed to do next generation imaging to know what is going on elsewhere. And when we do the next generation imaging, on the top you'll see the PET CT scan, on the bottom you can see the whole body MRI scan. You can see that that right acetabular lesion is in fact metastatic. And if you looked at the rib, again, you'll see that the rib is metastatic. And if you looked at the spinning image on the right-hand side, you can see that this patient's got polymetastatic disease. So he had equivocal lesions on bone scans and CT scans. We've done the next generation imaging, which is indicated, and it shows polymetastatic disease. So we seem to have some idea about the load. There's clarity on what is the truth, but what are we going to do about management? Because management is a problem. There is an issue about pelvic radiotherapy, and yes, we should do it. But what about the duration of adjuvant treatment? Normally, you would treat with high-risk disease with adjuvant treatment for up to 2 to 3 years. Now that he's got polymetastatic disease, do you treat for longer? I don't think we're very clear. And what choices should he engage in now that he is known to have polymetastatic disease? Should we use androgen signaling inhibitors, or should we be using docetaxel, which would be indicated for high-volume metastatic disease? So these are the choices and that are not very, very clear. Recently, this paper appeared in Journal of Clinical Oncology addressing this very issue. And you can see on the second row over there, if the conventional imaging is negative and PSMA is positive, then the pelvis should be treated according to what the conventional imaging says. So standard of therapy for the pelvis and pelvic lymph nodes. But what about for the metastatic disease? Well, it says you should prioritize clinical trials. But if you don't have clinical trials, what should you do? You should manage as if the patient was high risk. Why? Because not only the sensitivity of next generation imaging higher, the specificity is also higher. So these are very unlikely to be false results. So you should believe the results. The only problem is how you manage these patients. So the management should be based initially on the bone scans and CT scans with modifications introduced by the use of next generation imaging. Now, what about these higher volumes of disease? Higher volumes of disease at the start and higher volumes of disease later on. Here, next generation imaging's role is really in therapy monitoring and as part of clinical trials. So here's a man with locally advanced prostate cancer. You can see that he's got bone disease. And the role of imaging, next generation imaging here, is to monitor response. So here you can see he's had a great response to 6 cycles of docetaxel, which of course is indicated because he's got high volume locally advanced disease and high volume metastatic disease. So this is one role. And another role is in clinical trials. Now here is a man on a clinical trial using lutetium PSMA therapy in the hormone sensitive state. Of course, this is not licensed for this indication, but it can be used in the setting of a clinical trial, which is what you see here. And in fact, if you look at the guidelines and what they say about monitoring therapy, they say that in the hormone sensitive state, you should monitor patients using triple assessments: clinical state, imaging, and PSA changes. And the imaging should be done at the baseline at maximum response, usually at the end of treatment, to assess the treatment load and the overall treatment response, and then thereafter based on PSA and clinical studies. But the interesting thing is, the ASCO guidelines also say that if you had next generation imaging at the start, then you can use this to follow to see what the extent of progression is later on, and that's what we tend to use. And the reason they suggest that is that discordant responses do occur even in the setting of hormone-sensitive prostate cancer. So the triple assessment is what we should be using, but we know discordant responses occur between these triple assessment methods. So if you look at hormone-sensitive prostate cancer, you can see that you can have clinical and imaging progression in the absence of PSA progression in 30% of cases. Now clearly you see discordance more often, as you can see on the bottom there, in the castration-resistant state. Not so much in the hormone-sensitive state, but it does occur, and we need to be aware of that. So these are my conclusions. We know that bone scans and CT scans should retain the central role to direct the management of patients with hormone-sensitive prostate cancer, because it is convenient, affordable, widely available, and there's a skilled user base out there, and we know there are limitations and we have workarounds for that. It's powerfully prognostic with established roles in patient management, as I've shown. There are multiple predictive roles also. Use this therapy, pelvic radiotherapy in locally advanced prostate cancer, for example, with low volume metastatic disease. We know that it predicts for the lack of benefit of docetaxel in low volume disease that presents sometime after therapy, and it actually predicts for benefit if you have a locally advanced prostate cancer and lots of metastatic disease. So very, very powerful. We know that radiographic-free progression and metastasis-free survival are accepted drug development endpoints by the regulators. It doesn't seem to, these technologies don't seem to suffer from the biases of next generation imaging, such as lead time bias, length time bias, and stage migration bias. If you're really interested in those things, there are other talks on my YouTube channel where I discuss this in more detail. However, we cannot ignore the potential of next generation imaging, particularly for directing metastasis-directed therapy in metachronous low-volume disease. But the roles of next-generation imaging in terms of its management and survival impacts in other metastatic hormone-sensitive prostate cancer states remains less well-defined. I think we'll get there, but I don't think we're there yet. I hope you found some of these remarks useful for your clinical practice. Thank you very much for listening.